Today we're welcoming Nancy Miller, RDH. She's a practicing dental hygienist with more than 40 years of clinical experience, 15 of those at a periodontal practice. Currently, she's practicing 2 days a week with a general dentist in Green Bay, Wisconsin. She also runs her own consulting and lecture business called Ultra Concepts, where she presents lectures and hands-on courses on topics including ultrasonic instrumentation, air polishing for biofilm removal, ergonomics, assisted hygiene, and the business side of dental hygiene. She's a dental practice management coach with Jameson Management, and where she specializes in clinical department coordination with the business team and corporate relationships. She's a former Oral-B advisory board member. She was also one of Modern Dental Network's 25 Top Women in Dentistry for 2016. She's a key opinion leader and product evaluator for manufacturers, including Hugh Freedy Group, Crown Seating, Surgitel, Oroscoptic, Perioptics, and Florida Probe. Nancy, welcome to this welcome to our program here.
Wow, that makes me feel very tired when you put all those things in there. So,
well, we're really happy to have you here. I know this has been a very unusual time across the dental industry. Everyone's kind of had their own unique experiences throughout, and I'm hoping you can kind of just start off by telling me, what's the last couple of months been like for you?
well, it's been very interesting, just as it has been for most of us. I was still practicing back in March. Of course, we had been hearing about the COVID-19 virus, and then all of a sudden everything shut down. It's a kind of a unique feeling, the first time in my life that I was asked not to come into work someplace. So I think everybody was a bit, what do we want to say? We were trying to figure out actually what was happening, what was the extent going to be. The 2-week shutdown, certainly very, very different than what we'd ever experienced before. And as time went on and more is discovered about it, in fact, we really need to know even more about the particular virus, the SARS virus that's causing this. I think that we've all learned to kind of adjust and try to get as many information resources as we can to help us be able to go back into practice. I have been back practicing for the last 4 weeks. And the thing that happened, of course, was some of the patients that were scheduled, of course, they were a little more frightened to come in because the media has done an excellent job of pretty much terrifying all of us, especially dental patients, you know.
And that's actually something we've really tried to get out in the media space that we can, that dental practices are some of the safest places because they've been so focused on infection control and preventing the spread of communicable diseases from in that setting. And I guess that leads me to kind of the key word that's come up a lot since this coronavirus has really hit our country, and that is aerosols. Mm-hmm. Dental practices got very good at preventing bloodborne pathogen transmission, and there's lots of protocols there. How big of a concern were aerosols prior to coronavirus?
Well, to be honest with you, aerosols have been a concern and a kind of a specialty of mine, because basically my area of expertise is in ultrasonic instrumentation, going back nearly 30 years. And because of that, I've had to learn how to control it myself, and also how to teach others how to control the aerosol that is coming from different devices. Now we've moved on, we're using air polishing type products to do something called airflow, guided biofilm therapy. And even with those devices, of course, you've got another cloud of aerosol that's coming out. So I have learned different techniques and things that have actually assisted me in being able to control the aerosol that is coming out. I've always felt it was important, number one, to protect myself or the practitioner, as well as protecting the next patient or the patient that's in the chair.
Mm-hmm. So prior to coronavirus, what were some of the things that you were doing and you were recommending when it came to controlling this aerosol and protecting yourself and the patient?
Well, when using ultrasonics, you're creating not only an aerosol, but you're also putting a lot of water. You're actually waterboarding the patient, if you really want to know the truth of the matter. So we have two things that I had to learn how to control when we're using an ultrasonic. Number one is there's going to be water pooling and accumulating in the back of the patient's throat. That is where it's appropriate to use a typical saliva ejector, depending on what type the hygienist or dentist likes to use. But then you have the aerosol coming out of the front of the mouth. So for 20 some years now, I have actually used high-speed evacuation products. Now, there's a couple of things you can do to eliminate how much aerosol is coming out with your typical ultrasonic device. One is learning how to turn the power down so that you can control how much of that aerosol is created. And another is understanding the function of water in an ultrasonic. With the magnetostrictive type, cavitron type, that is intended to cool the handpiece. So you need to have enough water to do that, but you don't need so much that you're blasting everything out of there. Some of the products I've used in the past, basically I've kind of come up with my own system. You're going to have a high-speed evacuation hose that you would generally use, and sometimes in terms of what a hygienist needs to do it for herself, that hose is a little awkward and ergonomically a nightmare. It's kind of heavy. So I've learned how to put a lighter weight hose into that large hose that can then stay on the handpiece facilitator on the unit. And then I've also learned that the typical hygienist, we can't use the same size suction tip that, for instance, the assistant uses when assisting the dentist, or if they were assisting us. A typical 5.5-inch one is a little too long. It's awkward for us to use. So I had learned a long time ago just to cut them in half. And then there's a couple companies out there, Young is one of them. They make a product that's 3.5 inches long. That's a big improvement. And then Palmero, which is part of Hugh Freedy Group, we've come up with a design that's 2.5 inches long, plus it has 3 vents in this HVE tip, which allows us to be able to gather up a bigger plume of aerosol without suctioning in the patient's soft tissue. So everybody can kind of come up with what they want. These are things that have worked for me through trial and error, and I'm happy to share that with anybody. If you know, if they want to go to the Hugh Freedy website, I know we have some information there and some YouTube videos, that type of thing.
Mm-hmm. As you know, the pandemic really has impacted the industry. We've seen, you know, as you mentioned, practices shut down, they're reopening. Lots of different protocols right now when it comes to moving patients in and out of the practice. Lots of new PPE that people are wearing to protect themselves from the spread of this virus. Are you practicing in different, you know, equipment and doing different processes right now than you have, or is this kind of you were ahead of the curve because this was already on your radar?
Well, yeah, that's a pretty good question. I was a little bit ahead of the curve, but I also had gotten a little bit lax as to what I was doing with my own PPE protective equipment. You have to understand, I go back to the HIV days back in the 80s. When I first started practicing, and up until then, we didn't wear gloves. We didn't wear masks. We did very little, as a matter of fact. Thank goodness those days are gone. Thank goodness those days are gone. However, in terms of that, at that particular point in time, we were protecting ourselves and not realizing the patient's perceptions a lot of times. The first time that my patients saw me in mask and gloves, they were offended because they thought I felt they had the infection. Well, I didn't want to tell them, but I have to act as though every patient has that infection. And eventually now, if I wouldn't wear gloves or a mask with the patient, they would freak out from that. So what I've done different is I'm making sure that I'm wearing the appropriate gowns and coverage, and you know, things like you get a little lax about leaving your shoes in the office and stuff like that, all of that particular type of PPE. But now I'm also wearing the N95 mask, and I'm wearing another mask over that. So added protection. I feel the N95 mask, I thought it was going to be worse than what it was, but I'm actually grateful for it. It actually, my goggles don't fog up because it fits much tighter, even though I get a little breathless because I have a tendency to like to talk a lot when I'm with my patients. But it hasn't been a real big switch. Let's face it, in dentistry, we were already doing so many things right in terms of what we learned from the bloodborne pathogen. And then the same thing with just controlling aerosols, it makes common sense. You know, a couple of things to remember is trying to lower the amount of viral load, bacterial load that comes out of the patient's mouth to begin with. So it's always been critical to me, because of what we've been doing, creating these aerosols, that the patient does a pre-rinse. And in the past, we would use acetylpyridinium chloride. You know, there were several different products, but the one that I've researched out and felt probably had the most effect was just using hydrogen peroxide diluted. And the way we do that is we make it up each morning. It's a 1-to-1 portion with water. And then I just put a little dollop of the mouth rinse in there to give it just a slight flavor. Patients are so used to pre-rinsing in my office, that has not been a big factor. However, they've been grateful that we have actually addressed the idea that it may have more effect against a virus. And then your own personal protective gear. The patient's perception is very important. We need to make them feel safe. And that starts in the very beginning when we take their temperature, we're wearing masks, they're wearing masks, all that type of thing. But those are the three things I think are important. You need the pre-rinse after you've pre-evaluated the patient. We need our own PPE protection. And then we need to know how we can control the factor of the aerosols that is actually probably going to put that virus. We don't know for sure because the research doesn't show that yet. I think you're aware of that.
Yeah.
We still don't want all that bacterial load and everything else going out into the operatory environment.
Yeah. When it comes to pre-procedural rinses, I've looked at some research, and it seems like this is a really good mitigation factor. And I guess the one question I've still seen out there is how long it lasts, how long before there's a recolonization, especially for viruses and bacteria that are present within saliva. Do you ever, for longer procedures, stop and have them do a second rinse, or are you comfortable with the first rinse for now?
I'm comfortable with the first rinse, but you bring up a good point. I think I would have to look at that from the research factor. All the years that I've been doing a pre-rinse, I've only had them do it in the beginning. I know that I followed some of the research from Molinari and some of the other, experts out there. Molinari was one, I believe he said you can reduce nearly 90% of the bacterial load. What's different is we don't know about the viral load. We also don't know if that's, they think there's an oxygenation effect with the hydrogen peroxide against the virus. They're still doing research on it. I do believe there's iodine products too, probably povidone iodine that may be, but that really is nasty tasting. So.
Yeah. Do you think that the pre-rinse is going to sort of be just a standard part of most dental procedures before long for the people who haven't been doing it already?
Noah, I've consulted in a lot of practices, and I've been around the whole country, indeed places in the world. I don't know why people just don't do it automatically. I look at it as a comfort for the patient, because most patients, when they come in, about 100% of them think they have bad breath anyway. And the whole matter is, if I just poured some rinse in the cup and said, here, rinse your mouth, then they're going to be sure that I thought they had bad breath. What I like to do is present it in such a fashion that it's a benefit to them and to the next patient coming in. And essentially, I just said, we ask all of our adult patients to swish with this rinse. And now I'm adding this. We think it may have an antiviral effect, because my patients know we've been rinsing for 20 years. But basically, it'll help lower the amount of viral and bacterial load that goes in the overall office environment, and that can protect not only you, but the next patient coming in. So it's how you present it and more. And most of the time they're grateful because they think they have bad breath anyhow, and they're looking at it from that aspect also.
Now, you've talked a little bit about using HVE during these procedures, and you talked about some of the challenges. Do you think that this is a technology that has been adopted widely enough in the hygiene areas where these aerosols are, most commonly produced?
Up until 2 months ago, no, because I've been teaching it and I've been trying to get across to hygienists. The standard saliva ejector, the bore is only 4 millimeters. In order to adequately remove an aerosol, you need to have at least 8 millimeters across, which is your high speed function. Now, I don't use it continuously all the time because I also am pretty adept at using a saliva ejector that just stays in the patient's mouth and at lowering the amount of aerosol that's coming out. But I have found through the years that sometimes hygienists are a little hard to move and change, and I'm one myself, so I understand that. I do feel now they're becoming much more eager to learn, and companies are making products that are helping. There's different ones out there. For instance, there's the isolation type products. Dry Shield is one. There's several others out there. The most common, Isodry, some of these other ones. There's Mr. Thirsty. There's several different companies making different products that you actually can put into the patient's mouth and leave there. The problem I have with that is it still has a hard time overcoming the aerosol when it comes out to the front of the mouth. There's a device out there, I just saw it, that you can sit next to the unit. It's about the size of a big suitcase. I don't think that's going to fly in the dental practice. We hardly have the room anyway. And then there's another one I saw, you attach it to the HVE hose, and it's like a plastic shield, and it sits up above the face. The problem with that is the aerosol is from here to the plastic shield. You need to get it here. And that's why I feel that the HVE products that are out there are going to have to concentrate on me being able to use it in my non-dominant hand and right at the source where it's coming out of the mouth. And there's products out there to address that. It's a matter of getting them all together in one package, which I don't think somebody has adequately done yet. Let's just put it that way. There's parts and pieces to it.
But right now we have the tools to do to mitigate the aerosols, but we don't have the tools to do it as effectively as would be needed during treatment, essentially.
I know we have it. I think putting it all together, I get questions all the time. You know, what should I do? Where do you get this? How is that? The other thing that we have to understand is if you really are afraid of this aerosol situation and you really have concerns about it, you can just not use devices that create aerosols. I mean, you could literally use hand instruments for everything. That's a choice. And if you're going to do that, of course, I'd expect that you would use the best ones out there. And, Hugh Freedy Group, of course, you know, with their EverEdge 2, you want something that has a really sharp edge on it, because to be honest with you, one of the reasons we've gone to ultrasonic so much is to save us ergonomically. And if you're going to use hand instruments more, let's make sure you're using sharp, nice hand instruments that allow you to have the least ergonomic fatigue that's possible. And I know Hugh Freedy for a fact I think part of the reason I like their products is their alloys. They have some of the best metallurgists and procedures for making hand instruments, ultrasonic inserts, even things like their rubber dam clamps. They've got this black line of rubber dam clamps. You know, hygienists wouldn't use that, but the dentist would. And that's another way of protecting yourself from aerosols. But the black line, it's got a really good alloy, just like their hand instruments do. So it's bendable and it doesn't fatigue on you. And it's got a color contrast so that basically you don't get the glare if you're having your loop light or your overhead light on it. But those types of things make a big difference. There isn't one generic product, in other words, that I feel that you can use. You got to kind of experiment and see what works for you.
Do you think that in some situations having an assistant there to help with the HVE during some of these longer, scaling and other procedures might be helpful?
Well, that's a good point. The CDC, of course, recommends that. The ADHA recommends if you're going to do that, four-handed dentistry is the way to go, which is another topic I happen to talk about. I have worked assisted hygiene for nearly 20 years. Generally, I wouldn't have my assistant in there doing the HVE. I would do it myself. However, if you're not confident in what you're doing or you don't have the appropriate ultrasonic device that you can lower that amount of aerosols, certainly it would be wonderful to have a hygiene assistant person in there. I also feel that having a hygiene assistant for many different reasons is a way to boost the productivity, not the production in dollar terms as much as the productivity with a hygienist. But however, the circumstances are such that I do feel that most hygienists have to learn how to do this adequately on their own with their non-dominant hand in order to always have that right there.
Now, you talked a little bit about, avoiding some of these aerosol producing procedures. Is that realistic for every practice, or are there, some practices that really are going to need to use these mitigation factors rather than avoidance?
Well, I think they're going to have to use the mitigation factors. We do know that hand instruments and ultrasonics are totally as effective in lowering the amount of disease, like perio disease. It does come back down to ease of use and speed. So, I mean, when I worked in perio back in the 80s and early 90s, we were doing all hand instrumentation with number 2 handles. Those are those little tiny skinny things. I'm surprised my hand isn't arthritic at this point. But the reason it's not is I actually learned how to use ultrasonics back then, 30 years ago, which a combination of the two is probably the best, but you could certainly we all just use hand instruments before that. Lasers are another option. If the hygienist has a diode laser, you're still going to create some sort of a plume with that, but that's another option they can do to go along with the hand instruments.
Now, when it comes to just, getting back to the normal practice everyone kind of is looking to return to, early on there were the recommendations, don't do aerosol generating procedures, cut all these things. Now we're kind of back to it. Do you think that the public has an awareness of the aerosol issues that dental practices are trying to deal with? And do you think that, if you pull out the ultrasonic, you might have a patient who's concerned about that?
I think it's possible, but in the practice I've been in, we've used ultrasonics forever and they love it, as well as the airflow I've been using too. I think patients trust their dental offices in general, especially if they perceive that we're taking the steps to keep them safe. And the explanations that we do, the fact that that kind of overcomes some of the things they've probably read about in the media. Quite frankly, the number one most dangerous occupation right now is not even the dentist, it's the dental hygienist. And
Yeah.
therefore, I kind of look at it in terms of, if I protect myself, I'm worried about me. The patient's going to feel that I'm actually doing what's best for them. And so does explaining what's going on. And again, using the high-speed suction, if you have had a device in other offices that, there's more aerosol coming out, to be able to explain these things to the patient, I think goes a long way. I haven't had anybody come in and say that yet. I've had some people concerned because our receptionists weren't wearing masks when they came in. And so we had to come to a conclusion as a practice, we need to make the patient feel safe. Whether or not the receptionist feels she wants to wear it, or myself for that matter, we need to do it to make that perception for the patient, quite frankly. And so, yeah, I haven't had questions yet in answer to your question with the patient asked that, but I would be prepared to answer it if indeed it was asked because of the way we're actually treating them.
Yeah. And that really leads me to just, right now, obviously everyone is learning some new things as clinicians. How important is being able to translate all of these changes to your patients as they walk into the practice? I mean, do you need to have kind of your understanding of it for professional work, but also your plain language version of it that you can use to tell patients what and why you're doing it?
Yeah, that's an excellent point, Noah. And that's the whole fact of the matter is I have always felt, especially as hygienists, we are the premier educators in the practice. We all have the knowledge, dentists do too. Hygienists have the most amount of time, face time, so to speak, with the patient. And the whole idea is we have our business team is they prepare the patient before they come in. They're ready for the questions. They take their temperature. We explain as we go along. Like I told you, when they do a pre-rinse, it's not just here, rinse your mouth. Why are we doing this? They watch me put on the PPE. I explain what each piece is for. We go over the idea that we're controlling the aerosols using this and the other thing and what we're doing. And patients are definitely interested. If I had a patient say to me, I'm not comfortable with you doing that, I would just not do it. I would find an alternative way to do it.
Now, as other clinicians are continuing to adjust what they do and implement, new things if they weren't using HVE before, or if they weren't using a pre-procedural rinse or some of the other mitigation things, obviously there's some education involved there. If people are looking for further resources, they want to learn more about this and get themselves comfortable both working and talking to patients about it. Do you have things that you would point them to?
Definitely. First of all, Friends of Hugh Freedy is a group within the Hugh Freedy group for hygienists particularly, where they can go to the website, and there's a lot of continuing ed that's on there that they do an excellent job of trying to keep people informed. The other company I work for, Jameson, I've done a couple of webinars myself that are on their educational website that the people can access. There's YouTube videos out there. But the thing comes down to this. Once you get the piece of information, it doesn't just happen that you're going to know how to do it the next minute. The same thing is true. I think back to like rubber dams. Dentists don't like using rubber dams, but they're like a great thing to use. But that's because in school, they got frustrated with what they had to do. You can learn how to do it more efficiently, whether it's applying a rubber dam or learning how to control the aerosols. But you got to practice, and you got to find a system that works for you and not give up on it the first time that it doesn't exactly cooperate with you. So part of the way that you can really get around that is some of the wonderful webinars and things that are out there that you can access. Google HVE suction. I've done it myself several times. Go to different websites. Your website and your magazine DP. I mean, this is great. I get a lot of information on new products that I can go out and find out more about for myself. But that would be what I would suggest is, yes, you may have to re-educate yourself, especially if you weren't using HVE as a hygienist up to this point. And it's not like you can just go get the 5-inch one. And there are some things that will help you make it a lot easier. But I know I have a hygienist within my own practice. While one of them picked it up pretty easily, the other one was rather resistant. And now she has actually found something that works for her with my help and with her just practicing with it.
Hmm. And it sounds to me like overall, it's not one way to do this. There isn't just one solution to this challenge. And so does it really require a little bit of, personal testing and practice to figure out this is what my practice and my personal, solution will be?
It does, Noah. That's a really good point, because there isn't just one way to do everything. There might be a multitude of different ways. You need to pick out the one that makes sense to you and the one that works best in your practice. For instance, it may sound great to have one of those machines that's the outside suction device. You park it next to the patient and it's got this big hood. Practicality, financially, that may not be the best solution. Ventilation in an office, that becomes very important. The doctor that built my office over 25 years ago, they put in something called a negative pressure type thing where we have two circulating air constantly. There's all kinds of things you can investigate, and there's different ways of going about achieving what our primary principal function is, and that's to keep the patient safe as well as keeping ourselves safe.
Mm-hmm. And it seems like the bottom line is there's no way to avoid all risk in a dental setting, and there are ways to manage it and make it reasonable so that clinicians can be safe, patients can be safe, and we can get the care we need to the people who need it.
And that's exactly right, Noah. That's kind of the whole thing about what's going on in the world with everybody. It's the amount of risk that you're willing to take, but it has to be a calculated risk. And that calculated risk comes from informing yourself and making the decisions that work best for you and within your practice.
Mm-hmm. Well, Nancy, we really appreciate you joining us here today. I found this really informative discussion. Thank you so much.
Thank you. I appreciate the opportunity to share my knowledge base and my experience with other people. It's kind of my mission in life. So thank you, Noah and DPR.